everyone. My name is Marina Kranikos, and I work for the European Observatory on Health Systems and Policies. Welcome everyone to today's webinar. And I, together with my colleague Erica Richardson, will be moderating today's session on the lessons from Global Review of Health Systems Resilience. We are delighted to do this webinar as part of European Public Health Week, building on this year's theme of innovation for resilience and shaping a sustainable future. Over the past few years, the world has faced a series of interconnected crises, from pandemics and conflicts to climate change and economic shocks, and each of these has tested the limits of our health systems. And COVID in particular laid bare the vulnerabilities even in the most advanced healthcare systems, while also deepening inequalities in access, workforce capacity, and health outcomes. As we reflect on these challenges, we must ask, how can we build health systems that not only withstand shocks, but also adapt, transform, and emerge stronger? And that brings us to the concept of health system resilience. It's been around for a while, more so since COVID, but what does it mean for health system to be resilient? Today, we have a great lineup of speakers that will share their thoughts on how ideas about resilience have developed over the last few years. Also, what do they mean for future preparedness? And how can policymakers build stronger and fairer health systems? First, we have our keynote speaker, Steve Thomas, Edward Kennedy Professor of Health Policy, Public Health and Primary Care, and the Director of the Center for Health Policy and Management at Trinity College Dublin. Steve is going to talk about his recent monumental work that brings together resilience thinking from various shocks occurring in different parts of the world. Please, Steve, the floor is yours.
Great, thank you so much, Marina. Well, it's a real pleasure to be here and to share a taster, if you like, of our upcoming policy brief on lessons from a global review of health system resilience, which I'm very excited about, and we're just finalizing that now, actually. So, but let me just quickly see if I can get onto the next slide. There we go. And just before I get into the meat of the presentation, just to say a quick shout out and thanks to all my co-authors and the institutions and funders who've made this all possible. So thank you so much to them. Okay, so as Marina aptly said it, we're facing a new normal, which seems to be even worse than COVID. We're facing shocks and crises and potential challenges from every different direction, and we don't know what's coming next, including, of course, the ubiquitous climate change in this cartoon. I actually quite like the Hawaiian shirt that climate change is wearing, but we mustn't get lulled into a false sense of security about warmer weather being good. And so just in an understanding of kind of that context of that new normal, we need to have some new thinking about health system resilience. So through the presentation, we'll be looking at different sources of wisdom, looking at fresh insights around capacity, the dynamic nature of resilience and power, and then some of the key actions for resilience strengthening. And some of you may well know the previous work done by the observatory and the expert panel on health system resilience, which was very helpful around COVID. But as we're discussing, times have now moved on, and we now need to think about what are the new lessons that we can learn building on the previous stuff. And we're drawing on two sources today, the Elgar Handbook of Health System Resilience, which I have the privilege of editing, and then also the Practical Handbook for Resilience Testing, and Julia will be talking about that. In fact, actually, all of the presenters today are authors in the handbook. So just to give you a bit of background on the handbook, the scope and structure of it, there were 29 chapters with authors from all over the world, which was really exciting, not just Europe or even high-income countries. And we looked at different elements of resilience, think about theory, think about health system functions and resilience, but actually most of the book is taken up with looking at specific crises, and we can see it down here from the bottom pie chart. Many of those were related to pandemics, not all of them COVID, but actually there were a range of other shocks too. And so there's quite a lot of learning to be had from all of that. and 30 country case studies in all, a big focus on Europe, but not entirely. And as we can see, quite a lot from Asia and other parts of the world. And that, I think, adds to the richness of all this. But when we brought all this together and we brought all the chapter authors together from this global review, we actually found quite different perspectives on health system resilience, and there's a lot of learning in that. So in many high-income countries, many of you will be familiar with the shock cycle, going through a shock, seeing what do I need to do at each stage to be resilient. And in this kind of approach, there's a lot of focus on the economic aspects of shocks, on health system functions, on performance metrics, and seeing health system resilience as something that you try and achieve, something that's a good thing to achieve. And there's advantages in this approach in that every shock is seen as being an economic problem, in that you've got more needs, but actually a reduced ability to provide the resources that you need to meet those new needs. So there's an economic problem there. There's an evaluative element to this kind of approach, which is useful because telling you where you're at and highlighting the vulnerabilities and the need for strategic action. But there are disadvantages, I think, perhaps in some of the high-income country focus, and that's to ignore some of the underlying processes and relationships and the why, and we'll be digging into that a bit more. In contrast, a lot of the research and analysis done in low and middle income countries actually looks at complex adaptive systems and thinking a bit more about processes and capacity, and this sort of causal loop diagram that you see at the top, this spaghetti diagram. And their health system resilience isn't always seen as being a good thing. Sometimes there's maladaptation, which is where a health system, you get it through the shock, but actually you sacrifice health workers or you sacrifice vulnerable populations in doing so. So health system resilience isn't always seen as being a good thing. And in this sort of paradigm, health systems are very much embedded in other systems, and the relationships and processes for making you resilient are critically important. So those are the good aspects. The bad aspects, perhaps, of this kind of approach is often too context specific, and it forgets about the need to mobilize extra resources. So we have these two strong paradigms in the ALGA handbook. So the natural thing to do from that was then to pull it all together and see what new learning can we have in this if we combine these different approaches together. And this is really taken up in this framework then, this new conceptual framework, which adds to the shock cycle. We've kind of we've sort of amended the shock cycle a bit. We're thinking a little bit more about prevention than previously, separating prevention from preparedness, because prevention from climate change looks very different from preparedness for climate change, and prevention for something like cyber attacks is something that we can usefully do, and that's again different from preparedness. And at the other end of the shock cycle, we're thinking more about legacy, what the aftermath is, and drawing that out, because legacy is quite different from recovery. We can recover from a shock, but that doesn't really tell us how our health system is left. And that can be an important foundation for future health system resilience too. So there's that. So there's an amended shock cycle, but then in the middle of it, there's the capacity. What is the capacity that we need at each stage? And that's partly to do with the capacity stored in the system, and it's partly to do with the capacity that can be mobilized into the system to give us extra resources. And we can think about that in terms of hardware and health system functions, but we can also think about it in terms of software, in terms of relations, in terms of communications and stakeholders and processes, and things like that. And most importantly, we can think about it in terms of how health systems actually need to draw capacity from other systems that they're embedded in or they're nested in. And I know Laura will talk about that more. Other key findings, I think, that come from the global review is that it's no longer enough just to talk about resilience to a specific one-off shock. We're in the time now of perma-crisis, which is one shock after another, or polycrisis, which is everywhere, everything all at once kind of thing, like Russian dolls. And so we need to start thinking quite cleverly about how actually our resilience today is impacted by what happened previously. And there's this idea of cumulative legacy. And actually our workforce, if our workforce goes through austerity, it goes through COVID, it goes through cost of living crisis, there's almost a negative cumulative legacy being built up. And that can be then our preparedness or readiness for the next shock. And that's something that we need to deal with. We see that with the workforce, we see it with waiting lists. But there's also potential for transformation too with shocks. And they give us the option to change things and transform things. So we might talk about what the right conditions and things are to do for that. The other issue that comes out very strongly is stuff around power. And of course, we don't always get the leaders that we think we deserve. And there's a bit of a rogues gallery here of leaders who perhaps didn't do the right thing at the right time. And so there's a problem in that actually in response to a shock, our governance can be so bad that it actually makes the shock worse, not better. So there's the shock, which is a problem, and then there's a shock response, which is a further problem. And so we've developed this term called response resilience, whereby you look at what can I do in a system to deal with the fact that my leaders may not be any good? How do I develop that capacity? Another thing that comes through quite strongly is that vulnerable and the disadvantaged are always hardest hit in a shock. And if you wait for the shock to do something, you've waited too long. Things need to happen far before in terms of your preparedness. And then finally, dealing with austerity. Often there's a reaction, particularly with the cost of living crisis or with budgets tightening after COVID, people try to move into austerity, and we've seen that never works well. So a strong, resilient response is to contest austerity wherever we can. And if we really have to do it, we involve health workers, we involve managers, we involve providers around the table to say, okay, if we're going to make cuts, where do we make them to make the least damaging effect? Okay, so in the policy brief that you'll be seeing soon, very soon, we highlight 10 different actions that we can do to strengthen health system resilience. I'm not going to go through them all because I don't have time, but they're largely around smarter governance, accountable power structures, and a longer term, broader perspective. And we can come back to that, some of that in some of our chats and some of the other presentations. And then the last point I want to make is really about we're getting much better at understanding how resilient we are. And there are different promising approaches here. I think in terms of resilience testing, which Julia will talk about, systems dynamic modeling, which is the causal loop diagrams that I showed to start, which is often used in low and middle income countries. That's useful, that complex adaptive approach in understanding what's really going on behind whether or not we're resilient. And then also realist reviews, terribly important to thinking about how context impacts on our causal mechanisms to produce resilience or not, or fail to do that. So some really interesting, useful approaches that I'm sure we can all take forward and explore more. So it's almost lunchtime where I am. It's probably lunchtime where you are in Europe. So we need to have some takeaways for that. So let's think about some chow mein. So what are our key takeaways here? So resilience is all about capacity, not just performance. Accumulated negative legacy will undermine performance and resilience without attention. And then health system resilience is nested within other systems. And we really need to understand and register that, because our capacity for health system resilience will be reliant on other systems. So with that, I'm hoping I'm within time, and I shall stop there and say thank you very much.
Brilliant, Steve. Thank you so much. And way ahead of time as well. This was a great overview, and thank you for distilling these aspects of resilience and also all the mechanisms of coping with shocks. And it tells us how important it is to take broader perspective, also learn from various contexts and various shocks, and also be able to respond to issues that we have no control of, such as bad governance, for example. And indeed, we are working on the policy brief that touches upon so many of these areas and will soon be published to contribute to the discussion on how we take such a complex and versatile concept as health system resilience forward. And we will now go to our spotlight speakers, and I can see that we have Karsten's slide already on. We don't have Karsten on camera yet, but I think he's coming up. So we are very fortunate today to have Karsten Framberg, Laura Rosella, and Julia Zimmerman. And we start with Karsten, who is a professor at the Department of Political Science and the Department of Public Health, as well as director of the Center for Health Economics and Policy at the University of Copenhagen. Karsten will be talking about governance for resilience. Please, Karsten.
Yes, thank you, and it's a great pleasure to be here and to speak alongside such a lineup of really excellent speakers on this topic. So my idea here and for the chapter in the handbook is to emphasize that governance, of course, is a key element of resilience. And it's important to think about governance both as a prerequisite for achieving resilience, and that's what Steve was talking about. So in order to build capacity, in order to be prepared, in order to enable learning from crisis, we need governance functions that can pick up. But we also need to be mindful of what happens to governance during crisis and during crisis responses. So there's a risk that when we take rapid decisions in times of uncertainty, we may erode or not pay sufficient attention to some of the underlying governance values. So this is also a call for making sure that we revisit and that we consider the values embedded in governance and to take those into consideration. But let's start from looking at what we mean by governance. So going back to the WHO definitions, we see that governance functions include things like the delegation structure, the financing, the supply of services, the information to monitor performance, the capacity to do enforcement, etc. And what I'm doing in the chapter then is to say that if we want to look at governance for resilience, we need to add a more kind of a dynamic perspective, which deals with the capacity to learn and to adapt, or stated slightly differently, my slides are stuck now. Stated slightly differently, you could say we need a layer of what we could call meta governance. And what do we mean by that? Well, in a short version, you could say it's both the things we do before, during, and after a crisis occurs. So before a crisis, you could call that the constitutive meta governance, which is really the capacity to make informed and legitimate decisions about how to configure the governance forms and instruments in order to set up the preparedness for dealing with possible events and crises that might be coming up. Then during crisis, you need to be able to make governance decisions to reconfigure some of these governance dimensions in order to flexibly respond to the crisis. And then again, following this crisis life cycle idea, once the crisis is over, it's important to revisit the governance discussions and to be reflexive about what happened to governance, what worked well, what did not work well. So it's the capacity to evaluate, to learn, and to adjust the configuration of governance forms. So in other words, it's to consider the configuration of governance forms and performance both before, during, and after crisis. So how would we go about assessing that governance is actually working in a good way? Well, first we can summarize the definition of governance for resilience now, which would be the capacity to reflectively make and implement decisions that enable the system to respond and also to learn from challenges and shocks while maintaining performance and the ability to uphold key values. So what we're doing here is adding the two kind of assessment criteria, which is performance and the key values, the key governance values. Performance, we've got a number of different measures that can be used, so both process and health outcomes. I'm not going to go into depth with that. But let's take a look at the governance values, the key values that we should maintain. And here we can go back to sort of public administration literature. So Christopher Hood in 91 formulated this series of key values, rectitude, which is kind of a shorthand for fairness and due process, honesty, integrity, etc. Then frugality, which is efficiency as the second, and robustness as the third governance key value that should be upheld. That list is kind of similar to Scott Greer and others that emphasize the TAPIC framework, so transparency, accountability, participation, integrity, and capacity. And the point here is that in order for a system to be resilient, it has to have governance, and it has to look at governance values as part of what we want to achieve with the system in terms of the resilience. So, final point here. These issues could, of course, or should, of course, be evaluated looking at real-life examples. So all of our countries have gone through the COVID-19, which could be used really as kind of a looking glass for investigating the governance capacity and for how meta-governance worked in individual countries before, during, and after a crisis. And that's the end for me. Thanks.
Thank you very much, Karsten. And pay attention to governance. That's what Karsten said, which echoes very much what Steve has said previously, as governance is one of the areas that can help or hinder crisis response. And governance, of course, plays a key role in how health system performs throughout the shock, but also it is a function that is very difficult to assess because so much of it rests in fulfillment of its core values. And now we have Laura, so I will hand over to her. She's a second spotlight speaker. Laura Rosella is a professor at Dalla Lana School of Public Health, University of Toronto, and Laura will talk about resilient cities and how city infrastructure and dynamics can be important factors in resilience of health systems. Thank you, Laura, for joining us despite the huge time difference. Please, the floor is yours.
Great. Thank you so much. Good morning. Good afternoon from Canada. So I'm really pleased to talk about cities and basically emphasizing that health systems are not islands, and they're not solely responsible for health system resilience. Over 4 billion people live in cities, and this is projected to be about 75% of the global population by 2050. So let's talk about how we can enable health system resilience and think about what happens in how we design, govern, and invest in cities. This should be included in any conversation of health system resilience. In the book chapter, we focus on 3 building blocks that really are the basis of resilient cities that contribute to health system resilience: social connectedness, physical and social infrastructure, local governance and organizations. And the connective tissue of all that we talk about in the book is the data and analytics that's needed to make that happen. So let's talk about social connectedness first, which we argue has been somewhat undervalued in both its contributions to health and health systems, although it's getting quite a bit more attention recently. But the research, the theoretical research, as well as the empirical research, is clear that social cohesion and sense of belonging are really core determinants of health and resilience, and cities have a huge role to play in how they foster those social connections. We know that through public spaces, through policies, community-led programs, enabling that cohesion to exist in a city context really reduces the negative effects of all types of health shocks, facilitates equitable access to care, and buffers against the mental distress that we often see as a result of these shocks. It's really that social fabric, and not just the formal healthcare infrastructure, that determines how many communities weather a crisis, and there are several examples that we cover in the chapter. Next is infrastructure. Again, another critical enabler of resilience. And of course, we need healthcare infrastructure, hospital, emergency services, but we have to think about this in a broader sense. Transit, housing, reliable utilities. Again, those are controlled at the city level, and invested in and maintained before shocks hit and following thereafter. So there are these enablers of daily life, but really we make the connection of how they're enablers to resilience. And if we take that concept of infrastructure and broaden it even more, there are places called third places, as they're often known as in the literature, which are things like libraries, community centers. These things become informal health hubs, social anchors. We saw during COVID-19 how many of these third places were used in lots of different ways. And this broader idea of infrastructure is really critical. And then finally, the local organizations, which was touched upon already in terms of government. It's also local health organizations and community organizations that work together before, during, after a crisis. So when those relationships are strong, there's trust, there's strong communication, there's clarity of roles. And we see this in many shocks, and go through a few examples. Of course, again, we saw this in COVID-19, that this really was prominent in terms of a key force in vaccination and ensuring health services were reaching the full community. And then finally, just mentioning the data piece as sort of, as I mentioned, the connective tissue that I've described. So health systems generate a lot of data, we know that, but cities also generate a lot of data. And if these data systems are siloed, they're not focused on all those community elements I just mentioned, they can't support effective action, then it's really hard for us to use this in a crisis. We need this information, needs to be geocoded, local, to know where risk is concentrated, who's left behind. This is the intelligence we need to weather the types of shocks that we have been experiencing, and as mentioned, we will experience more. So building health system resilience is thinking about the environments where people live. And just one element to think of all the things we're talking about today, cities aren't just a backdrop to health shocks, they're actually central actors in our collective resilience and how we think about that. So thinking about how we design and govern cities is part of health system resilience, and thinking about social cohesion, adaptable infrastructure, trusted partnerships through community organizations, and using data to drive action is really key. Pause and thank you very much.
Thank you so much, Laura, for this fascinating presentation. And of course, city infrastructure and mobilization of social and physical resources can play a huge role in preparing for and addressing shocks, but also providing health system with valuable tools and also data and all this information. And this intelligence can be crucial in our ability to assess health system resilience. And to that extent, our final speaker and my colleague from the European Observatory, Dr. Julia Zimmerman, is going to talk about the health system resilience testing, the methodology that helps policymakers to understand and tackle health system weaknesses and build on existing strengths. Julia, please.
Thank you very much, Marina, and great to be here. In the next 5 minutes, I'll take you on a whistle-stop tour through our health system resilience testing approach. This is one of the approaches that Steve mentioned that can identify your health system's resilience, understand it, and improve it. So we developed this approach with our colleagues at the OECD, and with much thanks to many academics, public health professionals, and colleagues working at ministries of health across Europe. And what does it do? Well, most importantly, it aims to identify the cracks in your health system that are most likely to break if the pressure of a shock is applied. And second, most importantly, it can identify targeted, practicable options for remedial action to improve those cracks and make your health system more resilient going forward. It is a systematic approach that generates insight and evidence, and that fosters stakeholder participation. So we developed this approach to be as broadly applicable as possible. So you can take it and implement it in as many settings as possible. So we have done this at both a national level and a regional level, and we have done this using different shock scenarios across different domains. And we do this using a hypothetical shock scenario. So you can really tailor your shock scenario to the concerns that are pertinent to your country. And our handbook for resilience testing offers 4 worked shock scenarios across different domains. We have a climate change shock scenario, a pandemic shock scenario, a financial crisis, and an antibiotic resistance shock scenario that just showcases the breadth that this methodology can be applied to. And so how does it all come together? Well, the handbook sets it out in 5 different steps. For today, I'll take you through the pre-test, test, and post-test phases. So pre-test, you think about which shock scenario you want to run, what your context is, what existing projects and initiatives are there, and you look at existing data and evidence, existing actors and relationships, and bring that information together to prepare for the resilience test day. The resilience test day is a structured 1-day workshop that brings actors from across the health system together to discuss and assess health system resilience. So under health system resilience, we understand the factors within the health system that confer resilience and the factors within the system that detract from resilience. In other words, we're looking for strengths and weaknesses. And after the resilience test, there is a period of follow-up where all the evidence and insight gathered is made available for policy making. And this can take different shapes and forms depending on the context and what is desired. And we provide some examples for inspiration in our practical handbook. The link to the handbook should be available in the chat, and it is free to download and to use, and not only intended for a European context and audience, but also might be helpful for a worldwide audience. Do have a look. If you find it interesting and decide to implement it in your system, please drop us a line. We'd be delighted to hear about how you get on with it. And that's the end of my presentation. Thank you very much.
Thank you so much, Julia, and hopefully you have inspired some of our audience to download Resilience Testing Handbook. Please don't hesitate and try it on your own health system. I will now ask all the speakers to turn their cameras and join our Q&A session, moderated by our lovely colleague, Erica Richardson.
Hello there, everyone. Yes, quite a lively chat box. Greetings to everyone out there. Please do continue to get your comments and questions in. But just to kick off with a couple of questions. One is quite a big question, and it's how different shocks interact, given that we're in this sort of like poly crisis, ongoing, perma crisis. How do different shocks actually interact, and how do we need to prepare for sort of like multiple shocks hitting at once? Probably a bit of a hard question, but if we focus too much on cities, is there a risk that rural areas will be left behind? Because rural areas are often left behind. So how do shocks hit differently on health services for people in rural areas? And then a big question on governance, which is what is the role of like wider society, health professions, professions allied to medicine in governance, because we focus very much on the politicians at the top, but is there also like bottom-up governance that we should be paying more attention to? Thank you. And I'm going back into the chat box now.
Great. Shall I kick off on the interacting shocks? Fine, thank you. So I think this is a really interesting area and one where we are learning all the time. I think the one shock, or the one, if you like, cluster of shocks where we're getting increasing understanding around this is the climate crisis. And we're starting to see how the climate crisis cascades into other shocks, whether it's to do with disease burdens, or whether it's to do with economic shock, agricultural impact, things like that. And I think that's starting to become much clearer. But I think also actually there's a lot of learning which is probably latent around austerity and around COVID. and we're starting to see the long-term effects of what happens when you go into an economic shock, and it's not always immediately apparent what some of the problems are. And I think some of the actual the importance here is to actually understand it's not always about the shocks interacting, but it's what we do with them and how we respond to them. So in other words, when we responded to COVID, a lot of countries pumped money into their societies to keep them afloat. But in so doing, they actually primed the system for a cost of living crisis down the line. They primed the system for inflation. And so actually, which is a really difficult one, you kind of have to balance. You have to balance out, your interactions today with what impact and what legacy that you're leaving. So I think we come back to that whole legacy issues. And I think when you get one shock after another, there is always the danger, I think, that you don't get a recovery time, that you don't get to regroup, you don't get to regroup your finances. So I think it means we must be much more protective of our health system, particularly our health workforce, because we may not get that recovery time.
Thank you, Steve. Maybe any of the other panelists would like to respond as well?
So I think multiple shocks are really important to start looking at. And in a governance perspective, that really sort of increases the awareness that we should have about how we organize governance in order to have sufficient capacity to deal with multiple concurrent crisis elements. So that means that probably some of the lessons that we learned during COVID about reorganization and about scaling up capacity to process intelligence and make decisions, that those should be carried forward into the many new crises that we're facing. So that's the first part of the answer. The other part of the answer is that if we're facing multiple crises, then it becomes even more important to think about these governance values, because if there's a tendency that during a crisis we may suspend some of the regular kind of safeguards against sort of avoiding transparency, avoiding participation, etc., then really, if we have a permanent crisis, then there's a risk of eroding the governance values long term. So we have to be very mindful of what happens if we turn into a more sort of continuous crisis situation.
And crisis as early as possible. That's the message.
Yeah.
Thank you. Laura, I think you wanted to respond as well.
Yeah, I think that this idea of multiple crises is really important. And it's one of the reasons, again, to focus on some of the foundations that will actually set the stage for any type of crisis. And those are some of the things that I brought up. It's sort of like, focusing on chronic disease prevention, but only focusing on one disease. We know now that's not the best way. We have to think of how they manifest multiple diseases at the same time. It's the same idea. And I think when we get locked in to one particular type of crisis and one particular type of solution, that's what gives us some challenges.
And I think also Erica mentioned, so what happens to rural areas? How do cities not crowd out the interests of the rural areas as well?
Yeah, this is a really important question. So I'm very happy that this got asked. We look at cities as sort of an idea of focusing on place and where people live and their environments and their community, and everything that comes out applies to rural areas as well. So social connection, the infrastructure that exists, the strengthening of community organization to be involved in the response. It just might take a slightly different focus and flavor in small or rural areas versus larger areas. And so cities, actually, the definition of cities is very broad. It can be 1,000 people, it can be 3 million people. And so really focusing on those elements is critical, but there does need to be at a higher level, someone looking at the distribution of services to ensure that extra attention is paid to rural areas, because there will be additional considerations that maybe not exist in other areas, especially around access. But focusing on those principles of building, social cohesion, seeing infrastructure as part of the response, as well as bolstering community apply in rural areas as well as urban areas.
Thank you. Erica, do we have more for the next round of questions?
Well, there was an additional question, which was on the role of wider society and healthcare professionals and so on. Should we take that now or wait?
Yes, please go
Go
ahead.
for
Why
it.
not?
Okay. Yeah, sure. All right. So I think what we saw during COVID was that it's really critical that both wider society participates, and that has to do with behavior, of course, and it has to do with trust in the governance that's being set out for the healthcare systems. And it's also critical that behavior among healthcare professionals is conducive to dealing with the crisis. So that means flexibility in regards to, well, working hours, working conditions, and sort of adjusting to normal operations. So wider society, healthcare professionals are really critical. And how do we deal with that in a governance fashion? Well, some of the tools that we have are to invite them in, so both the broader society and healthcare professionals in kind of consultations and communicative forums, and to shape agreements as we go along. And of course, the urgency of crisis can sometimes be a hindrance to do that. But I think it's really critical because these behavioral changes are so important for making things work in practice. So we do need to think about how we can extend the governance beyond the very formal center states-ish governance to also look into how cities collaborate with the wider society, and how we can do these interactive forums with the population in general and with the healthcare professionals.
Thank you, Carsten. Completely agree. And Julia?
Thank you, Marina. If I could just quickly reflect on the question about multiple shocks from the point of view of assessing and testing for resilience. Well, this can be approached from two different perspectives. So if using the approach in our handbook, it is possible to run two shocks that happen in short succession or at the same time as part of a scenario. And we actually reflect that in the example scenario on climate change, where in addition to a heat wave, there's also a major electricity outage. And then we think through what that might mean for the health system. And the other angle from which to approach it is that all the legacy that has accumulated from recent past shocks is currently still reflected in the current thinking. So by thinking through what's currently happening in the system, hopefully you will be aware of some of these legacy effects that will therefore influence the resilience test from that angle. Thank you.
Thanks, Julia. I think we have lots of questions coming in the chat box. Erica?
Yes, I'm going to try and be quick so that we can hopefully get in another round of questions. But kind of quite a fundamental question is, how can we recapture the local empowerment and dynamic decision making that we saw during the COVID pandemic, while also ensuring strong governance structures and long-term planning? So sort of how do we balance that? Then how do we make the case for investing in health in the face of austerity, given that decisions are made by ministries of finance and not ministries of health? There's a question about new public management and the influence of new public management on governance and governance structures and the organization of governance, and how important it is for resilience. And then the a political one, the new WHO international health regulations tool, is it sufficient for dealing with particularly for dealing with polycrises? So over to you. I'm going to go back into the chat.
Okay, there's loads to go out there, isn't there? So I think on the austerity thing, how do you make the case? Well, I mean, as COVID quite clearly pointed out to us, if your health system goes down, your economy goes down with it. And so that's probably the strongest case that you could possibly make, that actually some shocks are so fundamental, and the health system is, they're so fundamentally challenging to your your society and your health system is so fundamental to economic well-being that if it doesn't perform, everything else gets shut down. So I think there's that immediate effect. I think there are the long-term effects too of going through austerity, of undermining your long-term investment. I think we're still paying the price for that. Actually, in the Elgar Handbook, we see country after country that went through austerity found their workforce on their knees through demotivation and demoralization, found themselves in a pitiful state in terms of their infrastructure development and their IT system, so that when COVID hit, they were kind of blown out of the water. And that a lot of that had to do with the fact that they were picking up the legacy of failing to invest. So you fail to invest, it brings your economy to its knees. It also, not only today, but it threatens to do that in the future. So I think that's one of the strongest cases to be made there.
Thank you, Steve. Anyone else wants to go next?
So on the interaction between local and central government or strategic governance planning, I think that's a very important issue, and it's also an issue that came up during COVID. So if for instance you look across the Nordic countries and the responses there, it was clear that the countries that were better at getting good linkages between what happened at the local level and sort of the strategic planning, those countries fared better initially. So how do you do that? Well, through collaborative frameworks. So in the Danish case, for instance, there was sort of ongoing negotiations between the state and the municipalities and the regions. So creating these institutionalized forums for discussing, conveying intelligence and conveying messages about the strategic approaches that you're taking centrally. So I think it's really important to keep these kind of negotiative forums alive and well, so that you do not hinder the local innovation and the local practical capacity building, which is of course important.
Yeah, and I'll just add on to that particular question as well, just emphasizing first how important it is, certainly in our setting during COVID on our vaccine response, when we kind of went through our typical system level. It was the lowest risk people that were getting vaccinated. And as soon as we turned it around, gave resources to community to deploy and organize, it completely turned our response around. So it's absolutely critical. The one point I just want to make is that you can't form that trust and that empowerment during the crisis. Ideally, it's formed before. So this means this type of activity of handing over, the authority around some of these things, empowering communities to take a lead in the response, needs to happen well before, and then it's much more effective. When it happens during, it takes longer and it's trickier. So what other aspects of health can be done in conjunction with community before, during the quiet times, if there are going to be any, so that when the crisis hits, that process is much more seamless?
If I can just jump in again to this this issue of sort of centralized versus decentralized. I mean, I think certain shocks encourage government to kind of centralize things, like often with a financial crisis, but it's sort of like there's a consolidation that goes. I think when you get something like COVID and there's resources being spent, there's actually a tendency to push it out instead. But for some shocks, there's almost like this centralizing tendency and a top-down tendency, and I think then that backfires, because then that's when you centralize power, you make bad decisions, so you get the system suffering from bad decision making in the shock, which makes it worse. And then you also start to disempower the workforce and the population at large. So I think that there's got to be a way of trying to find a system whereby when you get into a financial crisis, you don't immediately centralize everything, that you keep the communication open, particularly with your workforce, because I think distributed power is incredibly important for your resilience. And one of the case studies in the Elgar Handbook from Brazil shows how the system was able to work around Bolsonaro because there was a fair amount of distributed power with health workers and with communities, which then allowed them to actually make good on vaccination, make good on health system delivery, even when you had quite poor leadership.
Thank you. Yes, and it's incredibly important to have those mechanisms in place. And maybe just my quick question to Julie is, how in resilience testing, is there a way to sort of account for these different interactions, or for how do you bring in different perspectives or different areas or levels of governance into the resilience test?
Thank you, Marina. I was actually going to come in just on that point to maybe tie together the two previous questions. So something we see again and again during these resilience tests is that many decisions that sit outside the formal definition of the health system have a massive impact on the resilience of the health system. For example, decisions taken by the Ministry of Finance, but also other institutions. And what we find crucial is to invite these people to the conversation, and similar to the last responses to the last question, make sure that there is a shared decision making so that there is good awareness of the balance of risks and benefits of the decisions that are being taken. And so the way that we deal with this issue in resilience testing, as I said, is we identify the actors in the system that are relevant to the kind of shock scenario that is being dealt with, and we bring them all to the table for the conversation to jointly assess and discuss resilience. Thank you, Marina. Over.
Thank you so much. Erica, we probably have last couple of, oh, sorry, Karsten. You want to add?
Yeah, no.
And then Erica.
Yeah, so it was on the question of modes of governance and the new public management and so on. And I think one way to think about it is that of course new public management has been sort of the flavor of the day for a while, but a lot of countries have also moved on and started looking more at new public governance or digital era types of governance or networked type of governance, and all of these sort of three modes are perhaps more important, as we just talked about, in regards to binding things together during a crisis. But then I also think during a crisis, you need to reassert kind of the traditional public administration values and operational practices. So you need to go back and strengthen the core capacity to do strategic decision making and coordination also across the different levels. So while new public management and contracting and private sector, of course, still can play a role during crisis, I think we need to kind of slant the emphasis more towards traditional public admin and networked types of governance.
Thank you so much. Okay, so one quick question for everybody, because we haven't got time for sort of like a full Q&A. I want you to look in your crystal balls and what's on the horizon and the multiple challenges that we're all facing in our health systems. What are you most afraid of, and what are you most about what's on the horizon, but also what gives you the most sense of security going forwards? Where are we doing well, and what do we need to look out for, basically? Over to you, Steve. We'll start with you. Why not?
Sure. What a question. I think what worries me is the unknown unknowns, how quickly things spring up on you. We're looking at preparedness across a number of different countries, and none of them was a few months ago predicting an economic crisis. But here we are in Trump land. What are we going to get now? So I think that there's always the unknown unknowns, which is bad. And then I guess the thing that brings me hope is that people like us and the people on this webinar are trying to make a difference and trying to build capacity and resilience, and that gives me hope.
Who wants to go next? Karsten, I think your mic is off. You go.
Yes. So I think the worries are the same, of course, that we get these multiple crises and that they interact, which can make them more difficult to deal with. And the hope or the comfort would be in looking back and seeing that we've actually managed crisis before, and that we have also managed to learn from some of the previous crises, learn both in terms of how to build capacity and how to be flexible in the response when things occur. So hopefully we can do that again. The problem is these very protracted, very long-term issues. So climate crisis, which is not really, which just doesn't really follow the same pattern. So it's just ongoing and stays with us, and it's much harder to generate the same type of political dynamic behind it, particularly as other crises come in and kind of overshadow.
Yeah, I would say echoing, the thing that worries me is the complexity of crises, even, just a crisis that we may have weathered several years ago for many reasons, geopolitical and lots of reasons. It's much more complex. So that's one thing that I think that we don't have as much experience with, and that worries me. But I think what gives me hope is we do have the most information we've ever had more in society. We have these incredible data and tools. I think we can handle these in a smarter way with all of this intelligence. And so I'm actually quite optimistic that we're going to be quite sophisticated in how we can handle this complexity as we bring in all the new information, data, and tools that we now have.
Thank you, Julia.
Thank you, Marina. So I'm with Karsten on what worries me most, in that I think it's the long-term challenges. So if I look around me, things like the climate crisis, things like an aging population, we know about these things, but I see very little actual momentum and change. Whereas in an acute crisis, I think we actually do very well to recognize that help and change is required. So on the flip side, what reassures me is the same as Steve. I think if I look around me, there's lots of inventive people that, if a crisis does hit, come up with ingenious solutions about how to overcome hurdles. So I find that very reassuring going forward. Thank you.
Thanks so much, everyone. And also thank you for sharing on what keeps you up at night. And I just want to reflect that health system resilience is, as you can see, incredibly versatile concept. And this webinar shows how it goes well beyond the health system boundaries and really depends on local context and environments, as well as global context and environments. And a huge amount of work has been done already, but health systems are facing new challenges, new realities, and this versatility provides us with space for new approaches and also collaborations in studying, assessing, and as well as strengthening resilience. So huge thanks to all of our speakers for joining us today for the rich discussion, as well as for your positive messages too there at the end. And thank you to our audiences for your presence and for your engagement. Please do join us for the observatory webinars tomorrow as well, in continuation of this series. So there will be a third webinar, and it's going to be on how to implement integrated care. You can see there on your screens. So please go sign up and have a great day, everyone. Thank you.